even in the UK, most people are still not clear, what am I taking? Is it body identical? Is it bioidentical? And what actually is the difference? And how is that some doctors say bioidentical is good? Other doctors say this is not good, you should be on body identical. If the doctors themselves are not agreeing and sure on something, where am I to stand?
Welcome to Hot Flashy, the #1 podcast in women's health on Good Pods. I'm your host, Anne-Marie McQueen, a journalist with 30 years of experience searching for the true truth. We are stepping outside of the echo chamber to figure out what is going on and what is best for us in perimenopause, menopause, midlife, and beyond. Okay, so it's great to have you on the podcast.
Thank you, Anne. Same here.
What got you interested in menopause?
Well, it's a long story, but to keep it short, as a general gynecologist, you see so many women coming to you during perimenopause, menopause. And sometimes you are in a situation where you have little knowledge actually about the whole menopause transition and what options these women have. A general gynecologist gets very little training into menopause. And that's where my interest kind of got a little bit more into what happens during the transition. And the more I researched, the more I found out there is so much more to learn. And that's my primary area of practice now.
And when did you decide to open your own menopause clinic with a partner?
That was 5 years ago.
So you were ahead of this current menopause revolution that's going on.
Well, I would say I'm a small part of it, and I'm glad it's happening because it was really, really overdue for a long period of time.
So we're just going to do almost like a primer because a lot of podcasts, a lot of discussions, a lot of articles, they sort of state things as if a lot of people know them. And I don't really know when you get down to it. And even me, when I get down to it, what we're talking about, what's in the research, what's actually being used, what the names are, and it's different between, I've noticed, the UK and the US. So first of all, from a research standpoint, synthetic hormones, synthetic estrogen, and synthetic medroxyprogesterone. Did I get that right?
Well done. Well done.
Okay, so tell us just like a little history and your understanding of how hormone therapy started with synthetic hormones and what they are.
Okay. So HRT, hormone replacement therapy for menopause, started somewhere around 1930s, 40s. So it's to kind of have a look at it, it's been there around almost for 100 years now. Initially, the hormones which were used were largely non-human or equine from horse. And also they were used in that fashion as synthetic hormone because some of the processes we have now to produce the body similar hormones, like the micronization process that happens with progesterone, they were not available at the time. So all they had to do is if someone had to take oral hormone, they could only synthesize it in the lab. Okay. And that's how the HRT started around 1930s, 40s, 50s, became very popular around 70s, 80s. So a lot of women started using HRT because it was thought to be one that would take care of any unpleasant menopausal symptoms, but it was also kind of sold in a way that it would keep you forever young. And so anti-aging sort of medication. Right. Then came the two big studies around 2002, 2003, the infamous WHI study, as well as the Million Women study from the UK. And those studies scared everybody because they came up with stark results saying if you continue taking HRT too long, you're going to develop breast cancer or heart disease or have stroke. And then the whole panic set in. Lots of prescribing got cancelled. The prescription rates reduced. Women who were already on established HRT found it very difficult to get prescription. The flip side of that was a lot of women then had to turn to antidepressants. So the antidepressant use went up. Here we are again 20 years later from those studies where we've kind of reversed that position. So with the new research, some more studies, and the nice guidelines in the UK, we now find that there are many women who could have benefited from HRT, especially if they had significant symptoms at the time. And so we now say, if your benefits outweigh the risk, actually HRT is not as dangerous as it was thought. And that's primarily because of the new hormones, the new type of routes we can give the hormones in, which we'll come to as a next point.
And somewhere along the line of this history timeline, there were developed bioidentical hormones, or I like the word you use, biosimilar. It's much more correct in terms of terminology. These hormones are more similar to what our body creates. But those were in play long before the WHI study and the study that you mentioned. So women were on a combination of them. Like women, some women were on synthetic, some women were on bioidentical. Yes. But the difference is at some point, because bioidentical hormones, as I remember them, I'm a child of the 70s. And I remember Suzanne Summers was using bioidentical hormones, and she was painted as a sort of crazy loon for taking that kind of hormones. And say Oprah, who's another seminal woman that I grew up with, she took bioidentical hormones, and they were demonized then to the point that she didn't really talk about the specifics of her hormones. As I understand it, along the way, pharmaceutical companies started making biosimilar, bioidentical hormones. And then they became okay, because before they were made in compounding pharmacies, but now you could get them mass produced and considered safer because each one has been approved and regulated and all that sort of thing. Do I have that correct?
Yes, almost correct.
Okay.
So let's look at the terms and the hormones we have. So that might make it a little bit more clear. So let's look at first the estrogens. So you have body similar estrogens, and you have what we call as the synthetic estrogens. The most common and the widely used synthetic, completely made in the lab estrogen, is the one that you find in the pill, which is called as the ethinyl estradiol. This is widely used across almost all the contraceptive pills, the preparations that we have. Now, this is something we don't recommend for hormone replacement therapy. And the reason for that is it is not body identical or body similar. It is actually very, very strong, supraphysiological, which is why it stops you from ovulating or releasing an egg, and that's why it's contraceptive. It is sometimes used as HRT for younger women, those who have premature menopause or premature ovarian insufficiency, because they also have to balance contraception with HRT. But generally, it's not physiological, which is why we say if you only need the hormone replacement, it's much better to take other body similar estrogens. What are the body similar estrogen? So here you have estrone, estriol, estradiol, and estetrol. There are 4 estrogens which the human body makes. Estradiol, or also technically called 17-beta estradiol, is the most effective and the most biologically active estrogen in the body. Estetrol is only made in pregnancy. Estriol is more relevant for vaginal health. So, most of the companies now, the pharmaceutical companies, do make body identical estrogen, which is the 17-beta estradiol or the Estriol. And that's the one that we get through all the products that we use now, whether it's the oral tablet, the patch, the gel, the spray, the implants, or the vaginal creams of Estriol. All of them are body identical estrogen. That's because they've all been made from plants, either yams or soya, and they have been made as identical to body's own estrogen. So gone are the days where we would use the equine estrogen, the Primarin or some other Premique preparations, because we are now focusing on human body identical pharmacy regulated estrogen. Now you'll ask me a question, what about bioidentical? The ones that you mentioned have been around for such a long time. Now, individual clinics use combinations of estradiol, estrone, estriol in their own formula. And that combination or compounded preparation is bioidentical. And the reason to separate the body identical from bioidentical is that when we say body identical, we are mentioning the regulated pharmacy-derived 17-beta estradiol or the estriol, nothing else. When we are saying bioidentical, it's a combination of plant-based estrogen. The difference being, if it's pharma-regulated body-identical estradiol, it's been studied for 5-10 years. We know what the randomized control trial says. What is the long-term efficacy and safety? If it's bioidentical combination unique to the clinic, It probably is efficacious, but what we don't have is the 5, 10, 15-year long-term safety data because there haven't been large randomized trial. And that's why it's got a bit of disreputation, or so to say, it's not recommended across different menopause societies because they like to see the long-term safety data, which is missing with the combinations.
Mm-hmm. And as I understand it, because I've been curious about compounding pharmacies, they're individual preparations, so it's very difficult to have those trials. It's almost like you're asking them for something that they can't probably produce.
That's right. So you would need a very large-scale randomized trial with absolutely same preparation, guaranteeing that the compounding pharmacy does all this process of investing in the research. And for many of those individual clinics or small pharmacies, it's probably something that they can't do. But that's where the catch-22 situation is. You can't recommend it to patients because you don't know the long-term data, but the pharmacies have very little funds or resources to do it. Where do we stand there? That's the difficulty.
You prescribe some of these bioidentical preparations in your clinic?
I don't. So I stick to the regulated body identical or the synthetic hormones, but I don't personally prescribe bioidentical simply because we don't have the long-term safety data.
Can I just stop for 1 second and say where I think this gets very confusing is that in the UK and a few other countries, the term body identical is great because it refers to this distinction. But, in America, people don't really know that term body identical. And everyone, I think, is quite confused, or many people are quite confused about what that even means, right? Because it lumps in the compounding with the FDA. And am I right on that? Like it's a patchwork globally.
Well, you're absolutely right. Even in the UK, most people are still not clear. What am I taking? Is it body identical? Is it bioidentical? And what actually is the difference? And how is that some doctors say bioidentical is good? Other doctors say this is not good. You should be on body identical. If the doctors themselves are not agreeing and sure on something, where am I to stand? And that is a problem we have worldwide, and especially in the Western world.
Yeah. When did body identical start being used in the UK? Do you remember?
Yes, I think the micronized natural progesterone has been around at least since the last 2 decades, widely used. But the preparations that were available were very limited. For example, most of them were vaginal preparations, very few were oral. And then again, the supply issue, the pricing was out of reach of many. So it's really in the last 10 or 15 years that gradually the body identical, the micronized progesterone and the estradiol has caught up really to the forefront.
And do you think the word body identical, the term, I think that was probably created by the pharmaceutical company to differentiate its offerings. Do you know a time when that started being used in the UK? Can you think?
I'm not sure exactly when the term came in. I guess my guess would be it all really took off after the trials of the WHI. So the last maybe 15 years, that's really when people started thinking we now really need to make sure that we are giving information about a natural progesterone versus synthetic. So let's come up with the body identical one.
One more thing about the synthetic estrogen. You hear often of women being offered the pill when they go in perimenopause. And you've already explained that it's much stronger. I've heard it can have 8 times the amount of estrogen as hormone replacement therapy. There was a huge article in the New York Times where the writer, she went through it was a really in-depth article, but ultimately she was put on the pill. And that was her solution. And it was a really odd article because, her solution is her solution. But what women are finding is they'll go to the doctor, they'll be hesitant to put them on hormone therapy, but they'll be gung-ho to put them on the pill. Can you just frame this of the doctor's misunderstanding? If they're gung-ho to put someone perimenopausal on the pill and unwilling to put them on hormone therapy,
yes,
this is happening. And how do you feel about it? Yeah.
It happens across the world, not just the US. It happens, I think, even in the UK and even in the developing parts of the world. The difficulty is that the pill is usually, although it has the same level of risk or sometimes even more, for example, the blood clotting or the risk associated with breast cancer, somehow these do not get highlighted for doctors or patients as much as a small dose of HRT would be associated with risks. Now, we have always argued in the past that if you compare pill versus HRT, more or less you find the risk of breast cancer is same. But you don't find doctors telling this about breast cancer when they prescribe the pill. But if they are going to give a prescription of HRT, the first thing they're going to tell the patient, you know that this is associated with risk of breast cancer. And that's the problem. It's, I think, the education and awareness that actually pill has synthetic hormones and it may have more or less similar risk profile to the HRT. But of course, individually difficult to comment, as you rightly said, because some women may still need contraception. That may be the only way she wants to have contraception, in which case then hormones and contraception together make sense with the pill. So individualizing is important, but the general impression, you're absolutely right, is that we don't talk the problems with pill as much as the problems with HRT get flagged up.
Yeah, we're still in a controversial time to be critical of the pill for a vast number of reasons.
That's right.
Right. Okay. That we don't need to tackle today.
That's another podcast.
Oh, that is. Yeah. That's a couple of books and a documentary, maybe. Okay. I'm just got a little bit more on estrogen because when the WHI and the study after came out, all the fears were focused on estrogen. And then, decades later, we have books like Estrogen Matters, which you can have different viewpoints on how well it's researched or not. I've heard some of your colleagues over in the UK love that book and quote it as their Bible. And I've heard other colleagues say, I don't mean your direct colleagues at your clinic, I just mean in the space, say that book is awful. And it's like, it's not, well, it's the studies don't stand up. Regardless, estrogen has been sort of like, like estrogen doesn't cause breast cancer. Estrogen isn't the problem. And while this is being discussed, we're having the emergence of perhaps the signal is coming from the progestin, the synthetic form of progesterone. And that's a distinction that barely anyone is making. So I just gave you a whole bunch of stuff, but can you just tell me what you think about that sort of weird situation that's going on? And then we'll get into progesterone and progestin.
Perfect. So with the hormones estrogen and progesterone in combination versus estrogen alone, and the WHI did a good job because they had two arms of the study, one where only estrogen was prescribed to women who had a hysterectomy because they don't need the progesterone to protect the lining of the womb, versus you had the ones who had the combined HRT, estrogen, progesterone continuously. Now, what did come out of the study, and it's really important to remember that this is a well-designed and it's a randomized controlled trial, of course, has its limitations, has its problems, but a randomized controlled trial is the gold standard for scientific evidence. So down the line, after all these years of 20 years of long-term follow-up, what we understand is women who took estrogen alone reduced their risk of breast cancer, while women who took the combined HRT, which is estrogen and progesterone for long-term, had a slight increase in risk of breast cancer, but no increased risk of mortality. So the only thing that was coming up is that a slight increased risk of breast cancer happening, but actually these cancers were early stage, better prognosis, picked up well, and so there wasn't any impact on them dying earlier. So it looks from randomized controlled trial data with a big study and a few other observational studies that estrogen is not the culprit. It actually reduced the incidence of breast cancer. It's the combination progestin or the progestogen that adds that risk. The problem comes is there have been other big papers, epidemiological, observational studies with hundreds of thousands of women published in big journals such as Lancet, which contradict that data. The observational or epidemiological follow-up data suggests that estrogen on its own, as well as estrogen-progesterone combination, both increase the risk of breast cancer. Mm-hmm. Now, that difference is the one that confuses healthcare professionals, also confuses women every time there is a headline in the paper. Actually, big paper on Lancet now says, even if you're on estrogen, your risk is increasing. Why that difference exists, why the two hormones act independently differently, we haven't yet figured out fully. But if I were to choose one set of data, it would be the gold standard randomized trial data, because for me, that is science. observational data always has lots of problems with confounders and other biases. So for me, the baseline is just as somewhat like NICE guidelines summarize, estrogen alone unlikely to change your risk of breast cancer. It's when the progestogen comes in, that's when it may slightly increase your risk.
And if you're concerned about a slight increased risk, even if it's only one person per thousand, you wouldn't want to be that one person, then progesterone, if you have a uterus, seems to be safer.
Yes, out of the existing option, the natural progesterone or the dydrogesterone, the body similar, which I'll come to later, they seem to be your best options.
Okay. And yeah, the thing with observational research is often people will get an indication and then they'll do a randomized clinical trial and it doesn't bear out. It doesn't, yeah.
Absolutely right.
I don't know about you, but I find a lot of doctors cherry picking. I love this word cherry picking, but I also don't like it because it's kind of like a weapon, but when I see a doctor who keeps putting up a study in the same study and it's an observational study, I always think, okay, but there is so much behind that. What do you think when you see that?
Absolutely. I think we all have been guilty, at least I have been guilty of that maybe on a few occasions. But it's a tendency to cherry pick the data that supports your hypothesis or your explanation. But I think if you have to be really, really scientific, you have to just look at everything. You have to look at the observations, but then really depend on a good, well-planned design study to prove or unprove that hypothesis.
So then when it comes to progesterone, what are a woman's options to offset the estrogen that she's taking, the estradiol, the body identical estradiol, and to do it safely and effectively?
So with the progestogens, you have three terms that are used. First of all is the natural micronized progesterone. So this is the same as the body identical estrogen we talked about. This one comes from yams and it's the body identical progesterone. The next is you have progestins. Progestins are synthetic ones. Like you talked about the medroxyprogesterone acetate, you have the norethisterone, you have the levonorgestrel, which is part of the Mirena coil. All of those would be classed as the synthetic progestins. And then you have a bigger term, an umbrella term, which is the progestogen or the progestagen. That includes both the natural progesterone and the progestins. Now, the best one at the moment, if you look at all the observational data, some of the trials which have happened, then the natural micronized progesterone comes out on the top. Along with, not too far, is the body similar dydrogesterone. Now, you might notice I've introduced another term, body similar. And I say body similar is because the difference between the natural micronized progesterone and the dydrogesterone, those two, is just probably something like extra UV radiation. So they're almost, when you look at their effects in the body, they're almost similar. There is a big study, that was the French study, which happened, which suggested that for the first 5 years of using the body identical progesterone, you don't have any increase in risk of breast cancer. And if you look at the next 5 years, there's not enough data, but the risk may be lower still than some of the synthetic progestins. So your best bet is taking the natural micronized progesterone, or the dydrogesterone is equally safe and effective with regards to breast cancer risk. And then you have the coil, the Mirena coil or the levonorgestrel, which is given in the uterus. And then perhaps you go to the synthetic progestins, which tend to have the 1 to 5 in 1,000 risk of breast cancer.
Because women, whenever I talk about this, they're like, oh my God, I'm on a Mirena coil. Like, am I doing the wrong thing? It's like, what would you say to people if they're on the progestins? It's not a panic situation.
It's not at all a panic situation. One of the difficulties with natural progesterone we are finding is it's not very good for bleed control. So a lot of women tend to have a lot of breakthrough bleeding problems with the natural micronized progesterone. And there have been calls recently with safety alert from the menopause societies to say, you got to be sure you're giving enough progesterone to stop bleeding and protect the lining of the womb. So if you are a person who does well on coil, And it's the progesterone, the natural progesterone may not work for you because you bleed a lot. That increases your risk of womb lining cancer. Actually, many women find the balance between the endometrium and the breast, the coil may be the best for you. So it's not a panic situation. It doesn't mean you've got a high risk on the coil. Yes, your risk may be slightly more, 1 in 1,000 or 2 in 1,000 more than natural progesterone. But overall, for you personally, individually, the coil might be better than the progesterone. So talk to your doctor about all this.
What is your take on the current, the UK is it's really happening where there's a large push for hormone therapy for a whole bunch of things that nice guidelines and guiding bodies around the world don't prescribe it for, like a whole bunch of longevity, anti-aging, preventing heart disease, preventing dementia, testosterone for energy, all these sort of things that get out there, and there's people bigging it up. And if you kind of like to say, hey, I don't really think that's bearing out in the research, then you're some sort of killjoy, or maybe you're not on the side of women. This is just my reading of it. What do you think about this whole thing that's going on?
Well, you've read it well, and I can tell that you've had some response to some of your podcasts or tweets before. And I'm in the same situation. Sometimes it's risky to put something out there which many people don't like. But anyway, coming back to the point, I think what is happening now is really good because I think this topic about menopause, managing menopause, for some women who have a difficult menopausal transition was always hidden, was always a secret. But now that it's out in open, actually, I'm surprised how many women who were living with their symptoms are coming forward and saying, I heard about this. I never realized I could have help. And when you see them in the clinic, you offer them some intervention. Doesn't have to be HRT, some non-HRT intervention as well. They come back in 6 months for a follow-up and you see the transformation. That is what is the satisfying part of the job. But what I say is HRT is not for everyone. At the same time, somebody who needs HRT should not be denied HRT. The revolution that's happening now is great. It's very clear from both NICE guidelines and the British Menopause Society guidelines that HRT is not something that is to be used as anti-aging or a formula to stay young forever or prevent disease. It's mainly aimed at helping women who have difficult symptoms during menopause. So if you are the one, you're having difficult symptoms, impacting your day-to-day life quality, HRT can really help. And as long as you feel that the benefits outweigh the risks like the breast cancer or the blood clotting, then it's your decision to continue and carry on taking it.
Okay.
The problem comes is we often tend to then start advertising the health benefits. We do know there are 2 health benefits because estrogen is great for bones, it's great for heart, it's great for blood vessels. So the longer you're going to take it, certainly these 2 will be better off in the long run. But estrogen in relation to cognition or dementia, nothing has been proven at all. We have some observational, animal, experimental data that says maybe if you take estrogen very early in perimenopause, early menopause, you might stave off cognitive decline later on. But that's very preliminary. It may simply be to do with the protective cardiovascular effects of estrogen and may not be a direct effect on the brain. What we need is human trials, studies, long-term data to say that maybe there is an impact on cognition. So we should certainly not be saying HRT prevents dementia at this stage unless we have better information in future. And again, there was a recent study you might have heard of with the European study that showed those who carried APO4 gene, women who had that particular gene, which is a risk for dementia, in them, early HRT did find benefit, preserving the brain volume, preserving their cognitive function. So maybe there is something to it, but we certainly are very early in this research and we should stay away from advertising anti-aging or anti-dementia aspects of HRT.
It sometimes seems to me that people really badly want to believe that it's the estrogen that's why there's so many more cases of women having dementia and Alzheimer's, that people want it. I feel like people so badly want it to be the estrogen. That's like a simple solution. But when you study, and I'm definitely no means have any expertise in this area, but just as a journalist, there are so many causes of dementia. Like there's just dozens of factors that seem to go into this, right?
Absolutely.
So it's just, I feel it's almost dangerous, this focus on estrogen.
Very true. Very true. In fact, in one of the recent posts that we created, we said lifestyle is key. HRT helps with a lot of things, but if you're going to have a terrible lifestyle, you have smoking, you have excess alcohol, you're not eating healthy, you have no exercise, that's not going to stop the problems that happen just because you're taking HRT. Everything that we face in midlife and later life is going to be multifactorial. Your lifestyle, your diet, your exercise, your stress reduction will have to go hand in hand. If you're taking HRT for symptoms, it may help, but that's not a primary intervention for long-term health.
And what if you're a woman like me who's having trouble getting hormone therapy, is managing for the most part with supplements and lifestyle, cleaning up my act big time. And I'm about to go through menopause, I think. I get so confused, and I know I'm not alone wandering around because there's these voices saying you need the hormone therapy or you're going to be diseased. And I don't know. I can't believe that nature, whoever created this transition, would leave me so vulnerable to disease if I'm just taking care of myself. Does that make sense? Like, what am I to do? What's your advice for someone like me and all the women out there who aren't on hormone therapy, don't maybe need it desperately in this moment?
Yeah. So if you don't need HRT for symptoms, for example, you're going about your daily life without feeling too many symptoms, you don't think that things like hot flushes, night sweat, emotional fluctuations, or other symptoms of menopause that we classically describe, they aren't impacting your day-to-day performance, you don't need to take HRT. All you have to concentrate on is what you're doing right, your health, your diet, your supplements, your exercise, and everything else that comes with good health. If along that journey, as you progress through transition, whether you're perimenopausal, early menopause, late menopause, you start experiencing unpleasant symptoms that really drive you down, and it can happen variably at any point for different women, that would be a time to consider HRT, see a healthcare professional who knows about HRT, discuss with them how much impact will this make to my symptoms, consider a 3 to 4 month trial if your symptoms are getting worse, and that will give you an answer. I often say, unless you've really taken HRT for 4 months, if you're confused about using it, it will give you an answer at that point. Because if your symptoms drastically improve, quality of life goes very high in those 4 months, you know the answer. You might need to take HRT for a short time and then come off it gradually. Okay. On the other hand, if after discussion with your professional, you think, oh, these symptoms are not still hormonal, or after doing a trial, the symptoms don't change, it's unlikely HRT will be useful for you. Stop it or come off it or don't try it. Okay. So it's really the quality of life that is the sole thing that will determine whether you should go on it. If you can manage without it and keep a healthy lifestyle, you don't have to necessarily consider HRT.
And what about this new messaging that is you can stay on hormone therapy for decades? You can take it for the rest of your life. You can take it if you're older. That's sort of new.
I think the messaging came about because a lot of doctors were restricting HRT use based still on the data from the WHI. So the plan was keep somebody on hormone replacement for the shortest time and the lowest dose, 3 years, 5 years, 7 years. Everybody used random cutoffs. The messaging is to get rid of that. But of course, it's individualized. A lot of women will find as they get to 60, 65, their benefits have sort of for health, in terms of long-term health, have been exhausted. And they will find they are able to come off HRT, stay on the lower dose without getting those symptoms they experienced when they were 55 or 57, and they will come off. A few, maybe 10% in my own practice, will continue to experience symptoms even when they gradually come off the HRT. Now, these are women who have atypical symptoms which are long-lasting. For them, staying on HRT into their 70s, 80s may make still sense because their quality of life is really poor. And as long as they are doing everything with their lifestyle to reduce the risks from HRT, they can stay on it. So individualizing is important. It doesn't mean everyone takes HRT till they die. I don't think that's right. But some may need to continue an HRT longer than others.
Okay, so this is this rare second menopause that you hear sometimes women talk about when they tried to go off their hormone therapy and they had a resurgence of their symptoms. It can happen, but it's not that common.
Yes. I think rather than calling it a second menopause, I would say your menopause never settled. So the reason you started HRT in the first place with the symptoms, if you hadn't taken HRT, you would still continue to have the symptoms into your 70s. Because you took HRT in between, that got disappeared. But the moment you come off, you start getting those symptoms back again, and you might have to go back.
And that's called unlucky.
I would say so. Very unlucky.
So in terms of women who can't take hormone therapy, who try it and it doesn't go well, what's your sense of why that is? Is it excipients, other ingredients in the hormone therapy? Is it their own physiological makeup? Do they have gut issues or autoimmune? Like, what's going on with them?
Well, to be honest, the answer is we don't know, to be honest. There could be so many factors, as you rightly pointed out, whether the medication itself or the patient characteristics, the absorption, how it's broken down in the body, the metabolites that are created, individual receptor variation in the hormone receptors across the body, sensitivity to different medication. You can actually write a list of 20 to 30 factors which can affect how a drug has an effect on the body. And so everyone is different. Some women I know who started HRT just could not take it even for a few weeks. They felt awful, as if they were taking a pill in their 30s, even with the lowest doses and different routes. So there is certainly such a wide biological variation and no one size fits all. So it's for you to try, find out what's right for you, and then make a decision which intervention is best for you.
And what's your message to women who are starting this in perimenopause? From all the women you've seen go through it, you must have seen hundreds, if not thousands, go through this. What's your take on it right now?
Well, my take on it is you are luckier than the previous generations. And the reason I say that is because you have a podcast like this to listen to. Mm-hmm. So all this information that's happening right now, every little bit that's being talked about menopause is really important. There are a lot of women who come and say, all I had to do was listen to XYZ or read this book or read this article. And it really gave me a link with all that I was experiencing. It doesn't mean they need to take HRT or an intervention. It just acknowledges what they're going through. So make use of good evidence-based information tools, websites, podcasts, books, whatever it is. But when you read and when you make a decision about how you want to approach menopause, make it evidence-based. So stick to resources where there is good scientific evidence, because as much as good out there on the internet, there is so much not so good things or scientifically inaccurate advice that exists on internet, which you should be careful about. Look at menopause in a very positive way. Not everyone is going to have horrendous symptoms. Most women do very well once they have gone through the initial hormone fluctuations and settled on to the other side. And not everyone needs lots of intervention. So as long as you're aware about what you're going through, seeking help if things go severe or very unpleasant, I think as long as you maintain your healthy lifestyle, aware about what's going on, you should be fine.
And last question, what's your favorite non-hormonal? You said sometimes women come to you and you give them non-hormonal interventions. What would those be?
It's a lot of things together. So usually with non-hormonal, you find that one approach will not be enough because there are so many different symptoms that the individual may present with. So it's a combination of focusing on lifestyle and to find out what may be missing in their nutrition or how you can improve that. Certainly a lot of advice with exercise, yoga, Pilates, different forms of other therapies such as homeopathy, hypnotherapy, acupuncture. We have links with a clinic which offers this as a holistic medicine therapy. You also have other bits, for example, CBT, psychotherapy, counseling, if it's mainly mood-related issues, focusing on problems at hand. Antidepressants, clonidine, anti-epileptics in severe vasomotor symptoms, say for breast cancer patients who can't take HRT. So many wide range of options. If you choose 2 or 3 of these which work for that individual, if the woman doesn't want to have HRT or would like to stay away, you can always find a combination that will at least reduce the worst symptoms.
It sounds like how I treated my perimenopause when I didn't know I was in perimenopause. Thank you. Thank you so much. That's really clear. It's lovely to speak to you. I really appreciate it.
My pleasure. Thank you so much for having me.
Hot Flash Inc. was created and is hosted by Anne-Marie McQueen, produced and edited by Sonia Mack. The information contained in this podcast is intended for informational purposes only and is not intended for the purpose of diagnosing, treating, curing, or preventing any disease. Before using any products referenced on the podcast, consult with your healthcare provider, read all labels, and heed all directions and cautions that accompany the products. Information received through the podcast should not be used in place of a consultation or advice from a healthcare provider. If you suspect you have a medical problem, i.e. menopause or anything else, or any healthcare questions, please promptly see your healthcare provider. This podcast, including Anne-Marie McQueen and any producers or editors, disclaim any responsibility from any possible adverse effects from the use of any information contained herein. Opinions of guests on this podcast are their own, and the podcast does not endorse or accept responsibility for statements made by guests. This podcast does not make any representations or warranties about a guest's qualifications or credibility. This podcast may contain paid endorsements and advertisements for products or services. Individuals on this podcast may have direct or indirect financial interest in products or services referred to herein. This podcast is owned by Hot Flash Inc. Media.